Good afternoon, all. Myself, Dr. Shweta. I'm going to discuss case number 4. The history provided was 30-year-old male complained of nasal obstruction and gradually progressive nasolabial swelling since last 6 months. The biopsy was performed. On radiology, patient was having the soft tissue density swelling in the both of the lateral wall of the nasal cavity and in the left nasolabial duct. The swelling was causing obstruction to the left maxillary ostia. I would like to call upon the representative from the ESIC hospital to discuss the case. One HE10 section and its scan image was provided. I'm going to project 4 representative images of the same section. Dr. Aniket?
Good afternoon. Hello. Am I audible?
Yes, Dr. Aniket. Yes.
Good afternoon, respected teachers, esteemed faculty, and colleagues. I am Dr. Aniket Jadhav from ESI PJ MSR, presenting case number 4. Yes, ma'am. Yes.
Yes.
Section studied revealed polypoid structure. This is a low power resolution can be seen. A polypoid structure can be seen which focally was lined by ciliated columnar epithelium. Subepithelium showed few unremarkable seromucinous gland along with fibrocollagenous tissue and well-formed granulomas. Well-formed granulomas can also be and noted along with multiple giant cells. Um, next slide, please. As you can see in this foci, multiple giant cells can be seen. Also can be seen a few foci of necrosis, and the granulomas were surrounded by histiocytes, collection of histiocytes, plasma cells, as well as lymphocytes and scattered eosinophils. Eosinophils are also noted in the same foci. Yes, here you can see eosinophils as well as multinuclear giant cell on the left side, also at 1 o'clock position and 4 o'clock position also. Also noted are eosinophils scattered in between. Yes, again at 12 o'clock, you can see eosinophils along with multinuclear giant cells at 1 o'clock. And few foci of necrosis at 9 o'clock can also be noted. Considering the above histomorphological picture, the diagnosis of mainly granulomatous inflammation, for which the following differential we considered. First foremost was infective etiology due to fungal. Second was Wegener's granulomatosis, and third was non-infectious granulomatous reaction. We ruled out non-infectious granulomatous reaction because absence of any contributory evidence such as presence of steroid injection, history of steroid injection, cocaine abuse, or systemic Crohn's disease. Wegener's granulomatosis was again excluded by us due to absence of vasculitis as well as concurrent clinical history affecting the lung as well as the kidneys. So the most probably infective etiology was fungal. And for fungal, to confirm the fungal etiology, we did 3 stains, PAS, GMS, as well as a Fontana-Mason stain. We did Fontana-Mason stain to mainly rule out dematicious fungi, which is a rare type of rare fungus which affect chronic, which is found in chronic sinusitis. This fungi have a presence of melanin in their cell wall, but this stain came out to be negative. Hence, when we examined PAS and GMS, we found broad spectate, broad septate fungal elements along with large amount of spore-like structures in the especially in the GMS stain. So our impression is granulomatous inflammation secondary to fungal infection. The causative agents can be either most probably mucormycosis or mucormycetes, or second we also thought of coccidioidomycosis. In mucormycosis, 3 different species we shortlisted. Most common was Rhizopus species, followed by Conidobolus cornutus, as well as Basidobolus species. The later two mostly cause granulomatous inflammations along either in skin or in nasal epithelium. A special vote of thanks to KJ Somaya Hospital for providing with the special stains. Thank you.
Thank you. Very
And
well
for
described.
confirmation of this, and for confirmation of the histopath, a culture of the biopsy, a part of biopsy should be sent for culture. which is quite which will help to confirm the exact diagnosis and the further course of treatment.
Yes, very
Thank you,
well
ma'am.
described, Dr. Aniket. Thank you.
Thank
Any
thank you,
other
ma'am.
opinion from the house? You can unmute yourself and can share your diagnosis. So there is a story behind this case. A 30-year-old male patient from the Palghar was diagnosed for the COVID-19 in April 2021. He was admitted at the COVID center and he recovered completely and get discharged. Then after 15 days, he again developed a nasal swelling and he again then admitted. The biopsy was performed there and was reported as a mucormycosis. Patient started on the treatment, but unfortunately, patient doesn't respond. So the patient referred to the JJ hospital. As rightly described by Dr. Aniket, there are all features he has already highlighted. I would like to just enlighten few features. Like there are predominance of eosinophils, then granulomas, foreign body type of giant cells, and this eosinophilic aggregates, which is of Splendor-Hoffley phenomena. It is a acellular eosinophilic material. However, on HE10 we could not able to find out any type of organism. Considering the COVID history and the history of steroid intake and presence of and this histopatological feature, we consider the diagnosis first as a fungal infection and second bacterial infection, that is tuberculosis. We did AFB stain, which was non-contributory. So we think of Aspergillus zygomycetes family, mucormycosis, conidiobolomycosis, and candidiasis. We did special stain on GMS. We found asepted hyphae with a obtuse angle branching, which were typically present on the at the center of this Splendor-Hoffley phenomena. We have till this case came to us, we have seen lots of cases of mucormycosis, but this was the first case which came across with this Splendor-Hoffley phenomena. Simultaneously, we did the past stain which showing the multiple zygospore in the cytoplasm of the macrophages as well as in this extracellularly. So we were going through the literature which type of fungus it is, and we also discussed the case with the ENT surgeon. The surgeons were very much sure that this is not looking like a typical mucormycosis and it could be some other fungal infection. So we went through the literature and we found that the Conidiobolo fungus shows this kind of Splendor-Hoffley phenomena. However, it is not a diagnostic feature. Here, the microbiological culture helped us and reported as a Conidiobolus coronatus colonies. So, we rendered the diagnosis of rhinofacial conidiobolomycosis. Patient started on the oral potassium iodide and itraconazole. There was a complete regression of symptom within 3 weeks. Few words about the conidiobolomycosis. It is caused by conidiobolus fungus, usually seen in young male, immunocompetent, and on Sabrodextrose agar, the colonies are glabrous, flat, white, powdery. So as a pathologist, while dealing with post-COVID fungal infection and classifying the fungus is a task. Aspergillus and Candida species can very well differentiate on microscopy depending on their septate nature, and in Candida pseudohyphae. But due to the overlapping feature of mucor along with the conidiobolomycosis, it is very difficult to classify them. But it is very important to classify them because the line of management for each fungus is different. Uh, I would like to share our post-COVID-19 fungal infection at our institute. While India was going through the mucormycosis pandemic, Maharashtra was on the topmost list. In the Maharashtra, Mumbai was the on the top list of presenting the mucormycosis case and the death rate. As a tertiary care center and the COVID-19 hospital, we reported more than 150 cases of post-COVID fungal infection. We have seen maximum number of cases in between May to September 2021. Maximum almost 80% of cases were reported as a mucormycosis. We have also reported the mixed infection, aspergillosis, candidiasis, and one case of conidiobolomycosis, which is the present case. Our maximum number of cases, the biopsy was from nose and paranasal sinuses. followed by orbital cavity. We have reported the 10 eyeball exenteration specimen and single case of invasion of cerebrum by the mucor. These are few representative images which we have came across in our in this scenario. We have never seen such kind of invasive fungus before. Here the mucor is showing the vasculitis, and in the next picture it is showing angioinvasion. This is the microphotograph taken from the orbital exenteration specimen where the mucor is causing choroidal invasion, and in the this is the next photograph taken from the optic nerve stump, and the mucor is causing perineural invasion. Recently, in the third wave, already the mucormycosis cases are started coming. So the take-home message from this study we want to give as in this COVID pandemic, as a pathologist, we are learning the viruses and fungi. Before this pandemic, the fungal infection was very rare, but now it has become more common. While dealing with such kind of cases like a present case, it is very difficult to categorize the fungus on histomorphology alone. Though the mucormycosis is a most commonly reported case, but there are so many other emerging fungal infection which should be considered. Also, the co-infection of the fungal infection should also be kept in mind. So here comes the role of microbiological culture. So while dealing with such a rare fungal infection, histomorphological and microbiological culture correlation should be done, as the actual accurate diagnosis can provide the line of decision in the is a main in deciding the line of management. It is very helpful for the patient as these are very fatal infection. Thank you so much.